Stroke, it's a word that carries a lot of weight, and for good reason. It's the third leading cause of death right here in the U.S.
Yeah, it affects, what, about 750,000 people every single year. Huge numbers.
Exactly. And maybe even more impactfully, it's the #1 cause of long-term functional impairment. But here's the thing, the really crucial part. Many strokes are preventable.
That's absolutely the key takeaway. And when we talk about prevention, a major focus has to be on carotid artery disease.
Right.
So that's what this deep dive is all about. We're, pulling back the curtain on this condition. What is it? How does it happen? How do we find it? And maybe most importantly, what can actually be done about it to lower that stroke risk?
And we've really dug into some solid sources for this.
Yeah.
Medical chapters, research studies, the kind of expert material that's got the vital info, but honestly can be pretty dense to wade through yourself. So our goal here is to kind of distill all that, pull out the key insights, the things you really need to grasp so you feel genuinely informed about this really critical health issue.
Think of it like we're giving you a guided tour of the essential plumbing system for your brain.
The plumbing system, I like that.
Because that's what it boils down to, right? The vessels getting blood, oxygen, nutrients where they absolutely need to go.
All right, let's start right there then, with that plumbing analogy. How does blood actually get up to the brain? It sounds simple, but I bet the details matter.
Oh, they absolutely do. Your brain is incredibly hungry for blood, needs a constant supply. And that comes mainly from 4 major arteries. You've got the 2 carotid arteries in the front of your neck.
Okay, the ones you can sometimes feel the pulse in.
Exactly. And then you have the 2 vertebral arteries, which run up through the back, through the spine.
Now, the carotids, those seem like the ones we hear about most often when talking about stroke.
They are, yeah. Especially for strokes that affect the front, the larger parts of the brain. The right common carotid artery actually branches off another vessel called the innominate artery,
Okay.
which itself is the first big branch coming off the aortic arch, that big curve your main artery makes leaving the heart. The left common carotid, it's even more direct, comes straight off the arch.
Interesting. Different.
And as they travel up into the neck, each of these common carotids usually splits, divides into 2 main branches.
And those are the internal and external carotids. Right?
Precisely. The external carotid artery, it kind of sits more forward, and it sends branches off to supply your face, your scalp, your neck tissues.
Okay.
The internal carotid artery, that's the one we're really focused on when we talk about stroke risk from this area. It heads straight up towards the skull base, and usually it doesn't give off any major branches until it's actually inside your head.
Oh, okay.
One of its first branches in there is the ophthalmic artery that supplies your eye. And then it just continues on to feed a massive portion of the brain.
So the internal carotid is like the direct superhighway to the brain.
Right.
What about those vertebral arteries you mentioned, the ones in the back?
Right. They start lower down off the subclavian arteries near your collarbone. They travel up the back of the neck, but they do it inside these little bony tunnels within your vertebrae.
Wow.
And they mainly supply the posterior or back part of the brain. That includes structures like the brainstem, the cerebellum, which handles balance and coordination, and the occipital lobe, which is key for vision.
And they all connect somehow.
Yeah, this is pretty cool. All 4 vessels, the 2 internals and the 2 vertebrals, they connect at the base of the brain in this amazing network called the Circle of Willis.
The Circle of Willis. Okay.
It's designed, in theory, as a sort of backup system. If one pipe gets blocked, maybe blood can reroute through the circle. How well that works varies a lot between people, though. But you can see how a major problem in a big feeder pipe, like the carotid, can seriously jeopardize blood flow to the brain.
Definitely makes sense. Okay, so that's the setup, the plumbing.
Yeah.
What actually goes wrong in there? What's the pathophysiology of carotid artery disease?
For most people, particularly as we age, say 65 and older, the main villain is atherosclerosis.
Right. Hardening of the arteries.
Exactly. We talked about the plumbing. Atherosclerosis is like corrosion and buildup inside those pipes. It's a disease that can affect arteries everywhere in the body, but it really seems to like places where arteries branch or curve, like that spot where the common carotid splits the carotid bifurcation.
So it's not just a simple clog. It's actually a disease affecting the artery wall itself.
That's a key point. It often starts subtly, maybe with fatty streaks even when we're younger. But over decades, these can develop into more complex fibrous plaques within the artery wall.
Okay.
The plaque grows, the wall gets thicker, harder, less flexible. And that narrowing, which we call stenosis, that's what cuts down blood flow and also makes the area unstable, prone to forming clots or breaking off little pieces.
And I recall our sources really emphasizing inflammation now. It's not just cholesterol.
That's been a huge shift in understanding, yeah. It's not just this passive buildup of fat. We now see atherosclerosis much more as an active inflammatory process happening in the vessel wall.
What triggers that inflammation?
Well, the sources point to several things. Maybe free radicals, the kind generated by smoking or uncontrolled diabetes, could be genetic factors. Some research even suggests certain infections, like chlamydia, might play a role in initiating or worsening that inflammation.
Interesting.
This inflammation then draws in immune cells, like macrophages, to the site. They get involved, they try to clean things up, but actually end up contributing to the plaque growth and making it less stable. So yeah, it's not just passive gunk, it's an active biological process damaging the artery.
That really adds another dimension. Now, one thing that seemed incredibly important was this difference between asymptomatic and symptomatic disease. Can you
Okay.
break that down?
Oh, absolutely fundamental. Yeah. Asymptomatic disease means you have significant narrowing, let's say 50% stenosis or even more in your carotid artery, but you have never had any symptoms related to it.
So you wouldn't even know it's there.
Exactly. Unless it's picked up by chance, maybe on a scan done for another reason, or if specific screening is done, you feel perfectly fine.
And that's where that kind of scary statistic comes in, right?
Yeah.
Even with no symptoms, there's still risk.
Precisely. The data we looked at highlights that even with asymptomatic stenosis of 50% or more, there's still an underlying stroke risk. It's estimated around 1% to 2% per year.
Which adds up over time.
It definitely adds up. Now, of course, and this is the crucial difference, that risk jumps considerably higher if you do start having symptoms, and we know the chance of finding this significant asymptomatic narrowing goes up with age. Maybe it's only 0.5% in your 50s, but it could be closer to 10%, maybe even more, in people over 80.
Okay, so symptomatic disease is the big warning bell. And the most common symptom, the one people often hear about, is a TIA. Can you define that clearly for us?
Right, TIA, transient ischemic attack. People often call it a mini stroke.
Is that accurate?
It gets the point across that it's serious, but it's more accurately described as a warning sign of a potential future stroke. It happens when blood flow to a part of the brain gets interrupted, but only briefly. That causes temporary neurological symptoms.
So the key word there is temporary. The symptoms go away.
Exactly. That's what defines a TIA versus a stroke. The symptoms are identical weakness, numbness, vision changes, speech trouble, but in a TIA, they resolve completely. Usually they only last a few minutes, maybe up to an hour or two, though the technical definition goes up to 24 hours. They tend to come on suddenly. Think of it as the brain sending out an urgent but temporary low-fuel warning.
What are those classic symptoms, the ones that should make someone immediately think, I need to get this checked out, even if it's stopped?
Yeah, everyone should know these. The sources list them clearly. Sudden numbness or weakness, especially if it's just on one side, face, arm, or leg. Sudden trouble speaking or understanding speech. Maybe your words are slurred, garbled, or you just can't get them out right. Sudden trouble seeing, particularly in just one eye. People often describe it like a shade or a curtain coming down over their vision.
That curtain description is very vivid.
It is. Also, sudden difficulty walking, feeling dizzy, losing your balance or coordination. Any of those appearing suddenly are the brain basically yelling, hey, not enough blood flow here.
Absolutely critical signs to recognize. Now, atherosclerosis is clearly the main culprit. But did the sources mention any other less common causes of carotid problems?
They did, yeah. Though atherosclerosis accounts for the vast majority, especially in older folks. But they mention things like fibromuscular dysplasia or FMD. That's a condition affecting the artery wall, usually in larger arteries, often seen in younger white women. It's an abnormal growth of smooth muscle. There's also cervical irradiation. If someone's had radiation therapy to the neck, say for cancer treatment, that radiation can damage the artery walls over time and actually speed up atherosclerosis development in that area.
That makes sense.
Then there's carotid dissection. That's actually a tear in the inner lining of the artery wall. It can happen spontaneously sometimes. Or with trauma, even just vigorous neck movement, coughing, or vomiting in some cases.
Wow, really?
Yeah. And finally, arteritis, which is inflammation of the vessel wall itself, often as part of a wider autoimmune or inflammatory condition like something called the Takayasu arteritis. But again, for most people walking into a clinic with potential carotid issues, especially older adults, the underlying problem is almost certainly atherosclerosis.
Got it. So let's say someone has those risk factors, or worse, experiences a TIA symptom. How does the medical team actually figure out if carotid disease is the problem? What's the assessment process like?
It really starts with looking at the patient's overall risk profile and hammering home prevention. We keep listing those major risk factors: age, sex, family history, and then the big modifiable ones: smoking, high blood pressure, high cholesterol, diabetes, being sedentary, obesity, even stress.
And it bears repeating, hitting those modifiable factors hard
Hmm.
is where individuals have real power.
Right.
Right.
Absolutely. That's primary prevention 101, quitting smoking, probably the single biggest positive impact you can have on your artery health, period. Then aggressively controlling blood pressure, getting cholesterol and blood sugar numbers where they need to be, eating a healthier diet, getting regular exercise. These are the cornerstones. They're crucial whether you're trying to prevent disease or manage existing disease.
Okay, so prevention is key. But if symptoms have already happened, the patient's story must be incredibly important.
Oh, critical. Listening really closely to exactly what happened, the specific symptoms, how quickly they started, how long they lasted. If they resolved completely, that helps distinguish a TIA from a completed stroke. And it gives really valuable clues about which part of the brain might have been affected, and therefore, potentially, which artery is the culprit.
Like connecting symptoms to specific
Yeah.
arteries.
For instance, symptoms just on one side of the body, or that temporary blindness in one eye, what we call amaurosis fugax, often points towards the internal carotid artery on the same side as the symptoms. Whereas symptoms like dizziness, double vision, slurred speech, maybe problems swallowing, those might suggest an issue in the vertebral arteries or the basilar artery they form at the back of the brain.
Are there things a doctor can pick up just during the physical exam?
A few important clues, yeah. They'll definitely do a detailed neurological exam, checking strength, sensation, reflexes, coordination, and those cranial nerves we talked about. If someone reported that temporary vision loss, they might use an ophthalmoscope to look into the back of the eye, searching for tiny cholesterol crystals or clots called Hollenhorst plaques that might have traveled up from the carotid.
They can see that.
Sometimes, yeah. They'll also gently feel the carotid pulse in the neck one side at a time, never both together, because that can actually impede brain blood flow or stimulate sensitive nerve endings. They're checking the strength and rhythm of the pulse and feeling for any unusual lumps or masses, maybe an aneurysm or a rare carotid body tumor.
And the classic thing, listening with a stethoscope for a bruit.
Yes, auscultation for a bruit is a key part of the exam. Using the bell end of the stethoscope, they'll listen carefully along the path of the carotid artery, usually starting low in the neck and moving up towards the angle of the jaw.
What exactly is a bruit?
It's an abnormal sort of whooshing or rushing sound. It's caused by turbulent blood flow, usually when the artery is narrowed significantly or if there's an abrupt change in the vessel diameter. The smooth flow gets disrupted and you can hear it.
How do they listen for it?
They'll usually ask you to take a breath in, blow it out, and then hold it for a few seconds. That stops the breath sounds from interfering. The source mentions that if the sound gets louder as they move the stethoscope up towards the head, it's more likely originating from the carotid bifurcation itself.
Okay, so the history and the physical exam provide important clues. But to really nail the diagnosis and figure out how bad the blockage is, you need imaging tests. What are the go-to tools?
Right. These imaging tests are absolutely crucial. They let us see the arteries, measure the blood flow, and quantify the degree of narrowing, the stenosis. The most common initial test is the carotid duplex ultrasound.
Just a regular ultrasound.
It's a specialized ultrasound, yeah. It's non-invasive, uses no radiation, it's relatively inexpensive, and it's available pretty much everywhere. It uses sound waves that bounce off red blood cells to create images of the artery structure and, very importantly, to measure the speed of blood flow.
And the speed tells you about narrowing.
Exactly. Blood has to speed up to get through a narrowed segment, like water through a pinched hose. By measuring those velocities, experienced technicians can very accurately estimate the percentage of stenosis. It's so reliable now that many surgeons feel comfortable planning treatment based just on a high-quality duplex scan. Plus, it's the main tool used for follow-up after surgery or stenting to check if narrowing comes back.
What about MRI and CT scans? Are they used too?
Definitely. MRA, which stands for magnetic resonance angiography, uses magnetic fields, not X-rays, to create really detailed anatomical pictures of the vessels. It can show the plaque itself, the degree of narrowing, often from multiple angles. It's increasingly used, and many doctors now rely on a combination of ultrasound and/or MRA to make treatment decisions.
And CT.
CT angiogram, or CTA, uses X-rays along with an injected contrast dye. It gives incredibly detailed anatomical maps showing the aortic arch where the carotids originate, the carotids themselves, and the arteries inside the brain. It's also really good for ruling out other causes of stroke-like symptoms, like a brain tumor or bleeding, and it's useful after surgery, maybe to check for complications like a hematoma.
You hear about arteriography sometimes being called the gold standard. Is that still the case?
Historically, yes, it was considered the definitive test. Arteriography is invasive. They insert a thin tube, a catheter, usually into an artery in your groin, thread it up to the neck arteries, and inject contrast dye while taking X-ray pictures. It gives incredibly clear images.
But invasive sounds risky.
It does carry a small but real risk of complications, including stroke itself, from manipulating the catheter or dislodging plaque. So, with the high accuracy we now get from top-notch duplex ultrasound and MRI CTA, traditional arteriography is needed much less often. It's generally reserved for situations where the non-invasive tests give unclear results, or for very complex cases, or sometimes as part of an actual intervention like stenting.
Okay, that makes sense. So we've used the tests, we found the problem, maybe significant stenosis. How do we manage it? What are the treatment pathways?
Well, the absolute foundation, the first layer of management, no matter what else is planned, is that aggressive risk factor modification.
Back to the lifestyle changes and meds.
Absolutely. We talked about it for prevention, but it's just as critical, maybe even more so, once you know you have disease. Stop smoking. Control blood pressure tightly. Manage cholesterol, often with statin medications. Get diabetes under excellent control. Healthy diet, regular exercise. These things can significantly slow down plaque progression and lower your stroke risk, sometimes enough that more invasive treatment isn't needed or can be delayed. For some people with moderate stenosis and no symptoms, careful medical management and watching the narrowing with serial ultrasounds might be the chosen path.
And specific medications are key here too, right? Particularly the antiplatelets.
Yes, a cornerstone of medical management. Remember, platelets are involved in forming clots on top of unstable plaque. Antiplatelet drugs make them less sticky, reducing the chance of a clot forming and blocking the artery or breaking off and heading to the brain.
Like aspirin.
Aspirin is the classic, most common one, usually taken daily, often in a low dose like 81 milligrams, sometimes up to 325 milligrams. It works by blocking a substance called thromboxane A2, which platelets need to aggregate or clump together.
Are there others besides aspirin?
Yes, another major player is clopidogrel. Brand name Pladix is common. It works through a different mechanism, blocking another pathway called the ADP receptor on platelets. It's often used in patients who've already had a stroke or a heart attack or have peripheral artery disease to prevent future events. The typical dose is 75 milligrams daily.
Any others mentioned?
The sources briefly mentioned teclopidine, but it's rarely used now due to potentially serious side effects like lowering white blood cell counts. Prasugrel is another one similar to clopidogrel, but the sources know it carries a higher risk of bleeding, so it needs to be used cautiously, especially in older individuals.
What about anticoagulants, the stronger blood thinners like warfarin? Are they used for carotid disease?
That's an interesting point. Warfarin is definitely a mainstay for preventing clots in conditions like atrial fibrillation or from blood clots in the legs. But according to the sources we reviewed, its role specifically for treating atherosclerotic disease in the carotid arteries in the neck is actually considered controversial. Antiplatelet therapy is generally the standard medical approach for that.
Okay, so medication and lifestyle are fundamental. But sometimes you need to physically intervene on the blockage itself. What are the options there, starting with less invasive ones?
Right. There's percutaneous transluminal angioplasty, or PTA. That's where a balloon-tipped catheter is guided to the narrowed spot and inflated to stretch the artery open.
Like for heart arteries?
Similar concept, yeah. But for carotid arteries, PTA alone is generally reserved for non-atherosclerotic causes of narrowing, like that fibromuscular dysplasia we mentioned, or maybe stenosis that develops after neck radiation. It's not usually the first choice for typical plaque buildup.
And then there's stenting, which seems much more common now as an alternative.
Yes, carotid artery stenting, or CAS. This usually involves first using a balloon to open the narrowing, and then deploying a self-expanding or balloon-expandable mesh tube, the stent, inside the artery to act like a scaffold, holding it open.
Who gets stenting instead of surgery?
CAS has emerged as a significant alternative to traditional surgery. It's often considered for patients who might be at higher risk for open surgery. Maybe they've had previous neck surgery or radiation that scarred the area. Maybe they have severe heart or lung disease. Or maybe the blockage is very high up in the neck, hard to reach surgically. It's also an option for restenosis, meaning the artery narrowed again after a previous surgery. Patients undergoing stenting need strong antiplatelet therapy, usually both aspirin and clopidogrel, before and for some time after the procedure.
Okay, and that brings us to the traditional surgery, carotid endarterectomy, or CEA. Sounds like the most direct way to get the plaque out.
It really is the most direct approach. CEA is actually the most frequently performed vascular surgery in the U.S., and its goal is crystal clear: prevent a future stroke by removing the source of the problem.
How safe is it?
Nationally, the combined risk of major complications like stroke, heart attack, or death related to the procedure itself is quite low, reported around 3% in experienced centers. It's generally considered a very safe and effective operation, especially for patients with significant symptomatic stenosis, often defined as 70% or more.
Can you walk us through simply what happens during a CEA?
Sure. The surgeon makes an incision in the side of the neck over the carotid artery. They carefully expose the artery, including the spot where it divides, the bifurcation. Then they place clamps temporarily on the common carotid below the blockage and on the internal and external carotid branches above it to stop blood flow through that segment.
Do they bypass the blood flow?
Sometimes, yes. They might insert a small plastic tube called a shunt to maintain blood flow to the brain while the artery is clamped, especially if they're monitoring brain activity and see changes. Then the surgeon makes a precise cut, an arteriotomy, directly into the artery along the area of the plaque.
And just removes the plaque?
Essentially, yes. They carefully dissect the core of the plaque away from the inner wall of the artery, peeling it out. Once the plaque is removed, they close the arteriotomy. Often, to make sure the artery isn't narrowed by the stitches, they'll sew in a patch. This patch can be a piece of vein taken from the patient's leg or a synthetic material like Dacron or PTFE. It widens the closure area. Finally, they might place a small drain under the skin near the incision before closing the neck incision itself.
Wow, that is direct. It sounds effective, but how do doctors actually decide between that surgery or stenting or just sticking with medications and lifestyle? That must be where those big clinical trials come into play.
Absolutely. These decisions are very much evidence-based, guided by decades of rigorous research comparing the different approaches. One of the most influential trials ever was NASET, the North American Symptomatic Carotid Endarterectomy trial. It came out back in the early 1990s and was truly landmark.
What did NASET tell us that was so important?
NASET focused specifically on patients who were symptomatic, meaning they had already had a TFA or a minor, non-disabling stroke related to their carotid disease. And it found, quite dramatically, that for patients with severe stenosis, defined in that trial as 70% to 99% narrowing surgery, the CEA, was significantly better than the best medical therapy available at the time at preventing a major stroke down the road.
How much better?
The numbers were stark. Over 2 years, the risk of having a stroke in the group getting medical therapy alone was 26%. In the group that had surgery plus medical therapy was only 9%. That's a 17% absolute reduction in risk. Just a massive benefit for surgery in that symptomatic, high-grade stenosis group.
That's a huge difference. Okay, so that covers symptomatic patients with severe blockage. What about those asymptomatic patients we talked about earlier, the ones with significant narrowing but no warning signs? Does surgery help them too?
That was the next big question, addressed by trials like ACAS, the Asymptomatic Carotid Artery Study, and ACST, the Asymptomatic Carotid Stenosis Trial. ACS looked at asymptomatic patients with stenosis greater than 60%. It found that having CEA plus aspirin significantly reduced the combined 5-year risk of stroke or death compared to just aspirin and medical therapy alone. It cut the risk roughly in half, from about 11% down to 5.1%.
So a benefit there too. And ACST?
ACST was even larger,
Right.
primarily European. It also showed a clear reduction in the risk of stroke over 5 years for patients who had surgery, around 6.4% risk, compared to those managed medically, around 11.8%. Interestingly, though, when they looked at the combined endpoint of any stroke or death within 5 years, there wasn't a statistically significant difference between the groups in ACST.
So maybe some subtleties in the asymptomatic group depending on exactly what outcome you measure. Still seems like a benefit for preventing stroke itself, though.
Generally, yes. The consensus is that for carefully selected asymptomatic patients with high-grade stenosis, surgery likely offers a benefit in reducing long-term stroke risk, although the absolute benefit is smaller than in symptomatic patients, meaning you have to treat more asymptomatic people to prevent one stroke.
Right, the risk-benefit calculation is different. And what about comparing the surgery, CEA, directly against the less invasive stenting, CA?
That's where more recent large trials like CREST came in the carotid revascularization and darterectomy versus stent trial. CREST was huge and directly compared CS versus CEA in both symptomatic and asymptomatic patients who were considered standard risk for surgery. It provided a ton of valuable data comparing the outcomes, including the risks of stroke, heart attack, and death around the time of the procedure and long term.
What did CREST find generally?
In broad strokes, CREST found that the overall long-term rates of preventing stroke, heart attack, or death were very similar between CEA and CS. However, there were some interesting differences in the timing and type of complications. Surgery had a slightly higher risk of heart attack right around the procedure, while stenting had a slightly higher risk of minor stroke around the procedure. The risk of major stroke and death was very low and similar for both.
So, nuances again. Was there any trial looking specifically at high-risk patients?
Yes, the Sapphire trial focused on patients who were considered high risk for CEA surgery for various reasons. It found that in this specific group, stenting, using a particular system with brain protection, had favorable outcomes, actually quite comparable to surgery in terms of perioperative risks, stroke, death, or heart attack, were around 2.6% for CAS and 2.5% for CEA in that study. So research like CREST and Sapphire really helps doctors tailor the recommendation surgery or stenting based on the individual patient's symptoms, the degree of blockage, their overall health, and even the local expertise available.
That makes complete sense, using the evidence to personalize the treatment.
Now, shifting gears a bit, once someone has had one of these procedures, especially the open surgery, the CEA, what does their care look like right afterwards? What are the really critical things that the healthcare team and the patient or their family need to be watching for?
Post-operative care after CEA is absolutely vital, and our sources really highlighted several key areas of focus for the nursing team and doctors. One huge priority is monitoring for any potential alteration in cerebral tissue perfusion.
Meaning making sure enough blood is getting to the brain.
Exactly, making sure the brain is happy with the new plumbing situation. This involves keeping a very close eye on vital signs, especially blood pressure. If the pressure drops too low, the brain might not get enough flow through the newly opened artery. If it shoots too high, there's an increased risk of bleeding, either at the surgical site or potentially even within the brain itself.
So blood pressure control is key. What else? Frequent neurological checks are essential. Regularly assessing the patient's strength in their arms and legs, their sensation, their speech clarity, their level of consciousness, their vision, looking for any subtle or obvious new deficit that could signal a post-operative stroke or some other problem. And specifically, checking cranial nerve function is very important.
Right, you mentioned those nerves run close by. Which ones are most commonly checked?
The ones most at risk are the vagus nerve, cranial nerve X, which affects the voice and swallowing, the hypoglossal nerve, which controls tongue movement, the facial nerve for facial muscle symmetry, and the spinal accessory nerve for shoulder shrugging.
So what signs would they look for?
They'd assess the patient's ability to swallow safely, maybe asking them to take a sip of water. They listen for any new hoarseness in the voice. They check if the tongue sticks out straight or deviates to one side when asked. They look at facial symmetry, especially around the mouth when the patient smiles. And they check if the shoulders are level and if the patient can shrug against resistance. Any new problems in these areas need prompt attention, especially swallowing difficulty, because that increases the risk of aspiration pneumonia.
Makes sense. What about the neck incision itself? Bleeding must be a concern.
It absolutely is. Monitoring for hemorrhage or hematoma formation, that's a collection of blood building up under the skin, is another major post-op focus. This involves checking the vital signs again. A rising heart rate or falling blood pressure can indicate bleeding. Looking at the dressing for excessive drainage, checking the output from any surgical drain that was placed, and carefully inspecting the neck itself.
What are they looking for on the neck?
Any signs of bruising, or more importantly, any sudden or rapidly increasing swelling. A large hematoma in the neck is a surgical emergency because it can press on the trachea, the windpipe, and compromise the patient's airway. So nurses are vigilant about checking for neck fullness, difficulty breathing, or any sign that the trachea might be pushed off to one side.
That sounds like really intensive monitoring those first hours and days. What about when someone is getting ready to head home? What's the essential information they and their family need?
Discharge teaching is crucial for a safe transition and good long-term outcome. First off, it's another opportunity to strongly reinforce the prevention and health promotion messages. Keep taking the blood pressure meds, the cholesterol meds. Keep working on the healthy diet. And absolutely positively, stay smoke-free. Smoking just undoes all the good work.
And then the practical stuff about taking care of themselves at home.
Yes, the sources provide good examples of typical instructions. Activity-wise, usually patients can manage stairs okay and should be encouraged to move their neck normally to avoid stiffness. Heavy lifting, though, is usually restricted. Often the limit is nothing over 10 pounds for several weeks to allow healing.
What about showering and wound care?
Showering is typically fine pretty quickly. They should gently clean the incision area with soap and water and just pat it dry, no scrubbing. If there were staples, they're usually removed before discharge. If there are little adhesive strips, steri strips, they'll usually fall off on their own within a week or two. Patients need to be reassured that some bruising, swelling, and numbness around the incision are very common and will gradually resolve over weeks or months. And a practical tip for men: use an electric razor near the incision initially to avoid nicking it.
All good practical advice.
Yeah.
But the most important part of discharge teaching must be knowing when to call for help, right? What are those absolute must-call signs?
This is probably the single most critical piece of information for you, the listener, to take away if you or someone you know has this surgery. You need to report these symptoms to your doctor or surgeon's office immediately. Any new difficulty moving one side of your body, arm or leg weakness or numbness, any new difficulty speaking or understanding speech, slurred words, garbled speech, any loss or sudden change in your vision, especially that curtain-like symptom. Significantly high blood pressure, the source specifically mentioned reporting readings consistently over 170 systolic or 90 diastolic. A severe headache, especially if it's sudden and different from usual headaches. A fever, typically defined as a temperature over 101 degrees Fahrenheit or 38.3 Celsius. And finally, any sudden or rapidly increasing swelling, redness, or excessive drainage from the neck incision or the neck area itself.
That list is incredibly important. Those are the red flags that could signal a serious complication like a stroke, bleeding, or infection, and they need immediate medical evaluation.
Absolutely essential to know those.
Okay, let's try to tie all these threads together now with the case study you mentioned, MF, the 63-year-old man. How does his story illustrate this whole process?
Yeah, MF's case is a really good example that touches on many of the points we've discussed. He was 63, still working, when he experienced that sudden temporary blindness in his left eye. He described it like a shade being drawn down.
A classic ocular TIA, the warning sign.
Exactly. That very specific symptom is what rightly prompted him to seek medical help right away. His workup included, critically, the imaging tests. A carotid duplex ultrasound was done, and it showed significant stenosis. They estimated it between 70% and 79% in his left internal carotid artery. An MRA was also done and confirmed this high-grade blockage.
And his history, any risk factors?
Yes, his medical history was positive for both hypertension and hyperlipidemia, high blood pressure, and high cholesterol. Two of those major modifiable risk factors we keep stressing.
So he had a clear symptom, the TIA, a confirmed severe blockage, 70–79%, and known risk factors. What was the treatment decision?
Given that combination, a recent symptom directly related to a high-grade stenosis, he was considered an excellent candidate for surgical intervention to reduce his future stroke risk. This lines up perfectly with the strong evidence from trials like NASCET. So the decision was made for him to undergo a left carotid endarterectomy, which was performed the following day.
Okay, so he had the surgery. But his immediate post-op course wasn't entirely smooth, which really underscores the importance of that careful monitoring we discussed.
Precisely. About 4 hours after he got back from the OR, the nurse doing his routine assessment noticed some concerning signs. He was having difficulty swallowing, his voice sounded quite raspy or hoarse, and she noted that his neck, under the dressing, looked significantly enlarged compared to earlier.
Those are exactly the red flags you mentioned.
They really are. The difficulty swallowing and hoarseness immediately raised concern about irritation or possible injury to cranial nerve X, vagus, or 12, hypoglossal. And the rapid neck swelling is the classic sign pointing towards a developing hematoma at the surgical site.
And because the nurse was doing those checks and recognized those signs.
That prompt recognition triggered immediate further evaluation by the surgical team. The hematoma was confirmed, and it was large enough to be a concern, so MF had to be taken back to the operating room urgently for evacuation of the hematoma, basically, to reopen the incision slightly, remove the collected blood, and ensure there was no active bleeding.
Wow. But the outcome was good.
Yes. After the hematoma evacuation, His recovery went much more smoothly. He did well overnight, and he was actually able to be discharged home the following day. And you can be sure his discharge teaching included reinforcing all those critical signs and symptoms he needed to watch for and report.
His story really does encapsulate the whole journey beautifully.
Yeah.
The initial warning sign, TIA, the diagnostic workup pinpointing the problem, the evidence-based decision for surgery, the potential for complications, the absolute necessity of skilled post-operative nursing assessment, and ultimately, prompt intervention leading to a good outcome.
It really highlights how all the pieces fit together, from recognizing symptoms to understanding treatment risks and benefits, and the importance of follow-up care.
Well, this has been quite the deep dive into carotid artery disease and its undeniable connection to stroke prevention. We've covered a lot of ground, from the basic anatomy, the plumbing, if you will,
Right, understanding the pipes.
to how things go wrong, mainly with atherosclerosis and that inflammatory component. We talked about recognizing those crucial warning signs, the TIAs. We explored how doctors assess the situation using the patient's story, the physical exam, and those key imaging tests like ultrasound, MRA, and CTA.
And then we covered the range of management strategies, starting with that absolute foundation of risk factor control lifestyle medications like antiplatelets, and then moving into the interventions when needed, stenting, and the gold standard surgery, CEA, all guided by the results of those major clinical trials like NASCET, ACTS, CREST.
And the goal through all of this, for you listening, isn't just to absorb facts, but hopefully to feel empowered. By understanding these risk factors, maybe recognizing a potential warning sign in yourself or someone you know, knowing what kind of tests might be done, and having a sense of the treatment options, you're just much better equipped to engage in informed conversations about your health.
It's about being an active participant in your own healthcare, absolutely. Yeah. Knowledge really is power here.
Definitely. And maybe it leaves you with a final thought to chew on. Given that we know significant, potentially dangerous blockages can build up in these critical arteries without causing any symptoms whatsoever, how does that reality challenge our thinking about preventative health? Who should be screened? When? And when we do find disease, especially asymptomatic disease, what does that complex balance between the risk of the disease itself versus the small but real risks of intervening with surgery or stenting? What does that balance truly mean for each individual trying to make the best decision for their future health?